So I slightly modified the topic in the sense that why just discuss chemotherapy? There are a lot of other things happening in the lung cancer, especially with the metastatic lung cancer. So let's incorporate that also in our understanding and carry that forward in the topic. So bone metastasis is a big problem in lung cancer. It is one of the common sites for metastasis. And now with increasing usage of PET scan, we are finding more and more patients having bone metastasis at baseline, and around 40 to 50% of patients might have bone metastasis at baseline. The very important part about bone metastasis is they add a significant burden as far as the symptomatic burden is concerned. They have major amount of pain affecting quality of life, interfering with sleep. You can also have fractures, compressive symptoms, and yes, hypercalcemia. Also, many of the times patient might have concomitant bone marrow involvement, and cytopenias are a common manifestation. Then it really becomes important because the mainstay of the treatment many of the times is chemotherapy and doublet chemotherapy, and we are constantly thinking that should we modify the doses of chemotherapy, because chemotherapies again will cause some kind of bone marrow suppression. Some very important consideration. Compared to many other sites of metastatic disease, such as distant lymph nodal metastasis, bone metastasis portends a poor prognosis. Also, when it comes to taking a sample, bone is one of the least preferred options for the biopsy. There are technical challenges. Also, there is a longer processing time. And sometimes we see there is difficulty in doing a immunohistochemistry in the bone metastatic sample. Immunohistochemistry in lung cancer is very important. It helps us to differentiate small cell lung cancer versus non-small cell lung cancer. Also, the various subtypes of non-small cell lung cancer, such as adenocarcinoma versus squamous cell carcinoma. Also, especially in the lung cancer, the world has moved to newer horizons. We have now incorporated molecular tests for which we need big amount of sample, and a sample, and so not just FNACs, and a sample where the DNA extraction, the genetic material extraction is easier. So bone is not one of those sites. Why do we need these samples? Because we want to do analysis such as next generation sequencing, FISH, to pick up the various mutations so that patient can be considered for targeted therapies. We see both osteoblastic metastasis and osteolytic metastasis. Osteoblastic are more commonly seen in small cell, and osteolytic in non-small cell. So how to treat this patient? We have investigated, we have documented the site of bone metastasis in lung cancer. So it has to be a multi-pronged approach. There has to be symptomatic therapy. And when the patient comes to us, we also know that there are certain what is called as skeletal related events, SREs. This is a definition of SREs. If the patient requires radiation to bones, surgeries, or is there a pathological fracture, spinal cord compression, hypercalcemia, all these are SREs. So if this is happening, then to prevent these events, we need to treat the bone disease. This is not just by the anti-cancer therapy, but also something called as the bisphosphonates and denosumab. And yes, the mainstay of therapy, because the bone metastasis means that you have a systemic disease, so you have to take care of the systemic, you have to do the systemic therapy. Chemotherapy and the other groups of drugs which have now come in the lung cancer is anti-angiogenic therapies. So the drugs which are actually targeting the tumor blood supply, bevacizumab, ramucirumab, and newer in the list is immunotherapies such as nivolumab, pembrolizumab. Also, we now have targeted therapies. I just enumerated that yes, we are doing these tests to find out particular onco drivers, and one of them could be EGFR, L-cross, and other pathways. So yes, just to give an idea about the osteoclast inhibition. So when the patient comes, we evaluate, we find that, okay, these are the sites of bone metastasis. These are the symptoms and the problems happening because of the bone metastasis, and accordingly we address. But at the same times, we do something called as osteoclast inhibition to reduce SREs, which I just enumerated. So there are two groups of drug. One is the bisphosphonates. The most commonly used bisphosphonate is the zoledronic acid. At some point of time, pemidronate was also being used. The other class of drug is the denosumab. Now, in certain lung cancer trials have shown that denosumab might have a better efficiency in the terms of more delayed progression to first SRE. These both are in the form of injection. Zoledronic is also in the form of injection, and denosumab, but the route of administration is different. Denosumab is only a subcutaneous injection, so it might be much more convenient for the patient, but also it is much more costly. Zoledronic acid is intravenous infusion, and at some point of time we were all giving them once a month infusion, but now there is a practice change and some data is evolving, especially in other cancers, that you can also administer them once in 3 months with equal efficacy. They do have certain side effects. Both of them cause osteonecrosis of a jaw, hypocalcemia. So that is why it's very important to see the concomitant calcium levels and the vitamin D levels. Also, denosumab can cause urinary tract infection, and zoledronic acid can cause something called as bisphosphonate syndrome, which is like fever, chills, rigors, flu-like symptoms are very much common. And yes, it also requires creatinine monitoring. A brief discussion about cancer-induced symptoms, especially bone pains. It could be a background pain with episodes of breakthrough pain, which is defined as a sudden flare-up of the bone pain, severe enough to be perceived in spite of pain medication being taken. And bone pains are a very common cause of debilitating breakthrough pains. So we follow WHO pain ladder, that we start with the milder NSAID or the acetaminophen based painkillers, then we go to lower potency, then higher potency, and opioids, and we also take into consideration the other modalities such as radiation therapy. A very useful adjunct to the treatment are steroids, because they decrease the edema or the inflammation associated with the metastatic disease, and they are very much needed and used in the management of bone pain, and more so if the patient has spinal cord compression. So now coming to the anti-cancer therapy. So when the patients have bone metastasis, we know that in majority of patients it is with a palliative intent. So the quality of life and the treatment related side effects are very important. We tend to prefer combination therapies because they help us to achieve a better response rate. However, at the same time, we need to look into the patient performance status as well as comorbidities, and the risk benefit ratio of every intervention should be kept in the mind. Use the drug with non-overlapping toxicities, and now there are options which are combining chemotherapy drugs with immunotherapies or targeted therapies such as bevacizumab or the TKIs if the patient have EGFR inhibitors. And do consider if the patient has pre-existing cytopenias in deciding your line of management. This is the list to show what are the common chemotherapy drugs being used in the lung cancer. The mainstay of the treatment is usually in the first line, and in the combination therapies are either of one of the platinum, cisplatinum versus carboplatinum. Cisplatinum might be slightly more efficacious compared to carboplatinum. The other drugs are taxanes, paclitaxel, docetaxel, nab-paclitaxel, gemcitabine, vinorelbine, etoposide. Pemetrexed is a chemotherapy drug reserved usually for adenocarcinoma. Now, the site of metastatic disease in the form of bone does not make much difference to the efficacy of various anti-cancer drugs. Brain is a site where we know that not all cancer drugs have equal penetration. So there we look into drugs penetrating blood-brain barrier, but that is not so with the bone metastasis, and the extent of bone metastasis, type of bone metastasis does not make a difference to the choice of our chemotherapy options. A very important thing is chemotherapy associated flare, and this is very important from the radiology point of view. See, we have been hearing about flares in a lot of cancers, especially breast cancer, prostate cancer. It is a less common in lung cancer, however it is known. Why does it happen? Because it represents a rapid healing repair around the responding lesion. It might represent a successful response. So you have an increased activity of the healing process going on, and that is why you see a flare. So this is a borrowed case report where we see a primary and a bone metastasis in the humerus. And as the patient responded to the treatment, we see shrinking of the primary lesion. However, actually the bone metastatic disease showed increased uptake. So it was actually labeled as a progression. However, when the drug was stopped, the treatment, we see a progression in the primary, but the metastatic site continued to show a decreased uptake. Actually, the uptake went down further low. So flare is also should always be considered, especially in the bone lesions. It's a very important parameter, because if you're not considering flare, you might label patient as progression and change the treatment. And yes, so what happens that the patient becomes like, there was one useful regimen which was working well, and now the patient is no more receiving that treatment. It is somehow more commonly seen in non-small cell, but yes, also reported in small cell lung cancer. So yes, what beyond chemotherapies? Multiple newer treatment options, thankfully. So this is how the journey of targeted therapies and now immunotherapy is evolving. The EGFR was the first driver mutation found in the lung cancer, and subsequently we had EGFR targeted therapies. The beauty of these treatment is that the patient for a stage 4 cancer is simply taking a tablet and sitting at home, and he did not come to the OPD. So we are getting a lot of EGFR agents now. The journey started from gefitinib, erlotinib, afatinib, dacomatinib, and now osimertinib is latest in the list. And now we are getting more and more other targets also, such as ALK and then ROS, etc. Now we also have something called as immunotherapy. And yes, simultaneously at some point of time, the role of anti-angiogenic agents also came. The bevacizumab was the first agent introduced, and subsequently we also had ramucirumab. They act to decrease the tumor blood supply, and yes, that is why they act in synergism with the chemotherapy drug. Their use is more limited to the adenocarcinoma. Now, talking about the immunotherapy, what happens is when the cancer progresses, it has what it does, it kind of does a immunosuppression in the body. How does it do it? That there are kind of cells which also immune cells which are trying to kill these tumor cells, the T cells. So what it does is cancer expresses certain molecules called as PD-L1 ligands, and they bind to the receptor PD-1 on the T cells. So by binding these, there is an inhibition of T cell activity. So this mechanism is very important because as the cancer grows, it progresses, it causes the immunosuppression, the T cell immunity suppression, which is actually taking care of these cancer cells. So what the immunotherapy does, it works by blocking, getting rid of, so you have PD-L1 blockers, PD-1 blockers, by so that this step is taken care of. So there are various other kinds of immunotherapy, but the immune checkpoint inhibitors are the one which are being much more commonly used now. They are much more validated across the trials, and there are two kinds of immune checkpoint inhibitors. The more important and the more readily available are the PD-L1. The other group is CTL4 blockers. The ipilimumab is the drug which is used from that class. So just to give you a brief, insight into how are we actually managing the patients in a real world setting. So whenever a patient with a bone metastasis comes to us, we take all the history, do all the workup, and yes, we find out what are the histological subtypes, extent of disease, and then we do molecular testing, which I previously narrated, and we also do PD-L1 testing. So there is battery of tests which is being done, and after that, that helps us to decide our plan of management. If the patients, they don't have any targets, and if there is rapidity to control the symptoms, especially if the patient is having a lot of bone pains, we tend to start the patient on chemotherapies. There are chemotherapy drugs that I just enumerated, so we use combinations, and yes, many of the time we combine them with either immunotherapy drugs or also anti-angiogenic agents. So the drugs which are commonly used for adenocarcinoma, pemetrexed, carboplatinum or cisplatinum, along with immunotherapy drugs. So the immunotherapy drugs are pembrolizumab, atezolizumab, and yes, we also have other combinations of immunotherapies such as nivolumab and ipilimumab. So similarly, if the patient progresses on first line, we try to give the therapy which patient has not received in the first line, and this is how the stage 4 cancers are managed, also including those with the bone metastasis. Similarly, for the squamous cell carcinomas, we have various treatment regimens. And here again, the pembrolizumab, that is the immunotherapy in combination with chemotherapies, are one of the front runners in the treatment armamentarium. So for the small cell lung cancer, we again have platinums along with etoposide as the mainstay of first line treatment, but also now addition of various immunotherapy drugs. Now, as I said, there is a flare seen with this chemotherapy. The immunotherapy also can cause certain problems, which is called as pseudo progression. So whenever we are giving patients immunotherapy drugs, what happens? There is an immune infiltration of these cells. So actually, paradoxically, the uptake and the size of the lesion will increase. So sometimes there is something called as pseudo progression seen on the imaging. A very important word about various theranostics. So especially for the symptomatic management of the patients, there are few agents available to take care of the pain. If the patients have a lot of pain, and especially if we feel that they are not fit for any other chemotherapies, etc., and they don't have much time to live, strontium 89, samarium are few agents they are given, and they help to decrease the pain. However, they cause significant bone marrow suppression, and that can, of course, limit the subsequent use of chemotherapy, and hence they should be used very judiciously. Lutetium 177 is also the latest addition in this list. That is the use of this agent just for the control of pain. We might be using lutetium-177 as a part of PRRT therapies in certain cancer, and yes, PSMA therapy for the prostate cancer. But now this agent is also used as only for the pain control, and it might cause less bone suppression compared to the previously this strontium or samarium. So just to conclude, bone metastases are common in lung cancer. They add to morbidity, portend poor prognosis, and the treatment has to be a multi-pronged approach. Anti-cancer therapy offers best palliation, out of which we have multiple options to choose. And yes, that is the way to go forward. Thank you.